for to get a visual impression on things. So what you have to know is liver failure or liver diseases affect almost all the systems in our body. So we have to know what are all the various pathologies that happen in the various systems. So hepatic failure can occur due to either hepatitis, which is either as a viral, alcohol, or drug induced, or it can be chronic as alcoholic, nutritional, or idiopathic. And it can manifest acutely or chronically, even to go to the stage of end stage liver disease or decompensated liver disease. So if you just mention this much is more than enough. We need not describe about the various grades of encephalopathy, how the origin is happening. All this pathology is not required. Okay, it's just so that you can save time on that. And the functions of the liver can be remembered by the mnemonic A, B, C, D, E, G, F, H. A for albumin synthesis, B for bilirubin secretion, C for coagulation factor, D for drug metabolism, E for excretion of toxins, F for fat metabolism, G for glucose and glycogen, H for hormones, and I for immunological function. So what are the effect of hepatic dysfunction on anesthesia? You can start with these various functions that are affected. Okay, so once you enumerate the functions, you know how the changes that happen in these functions will affect your anesthesia. That should be the approach to this answer rather than prescribing detail everything. Okay, so decrease in albumin increases the free fraction of all the drugs that you give because protein binding is not there. Free active fraction will be more, and that will also cause altered volume of distribution because of the ascites and increased body water compartment. And because drugs are reduced, metabolized very slowly or incompletely, it alters the drug pharmacokinetics. Okay, so that is the first point that you have to think about. Then immediately after that, you can talk about the risk assessment that is going to happen. So before you talk about the other systems that are going to happen, you can start the first and foremost thing to take care of before you anesthetize a patient with liver failure is assess the risk involved in the patient based on the Child-Pugh score. Of course, this MELD and other things are all mainly for the other systems. So you can just make a casual mention of these names, but describe in detail about the CPT scoring. So this is the Pugh-Turcotte Child-Pugh scoring system, where it takes into consideration the albumin, bilirubin, prothrombin, ascites, and grade of encephalopathy. Earlier it was nutrition, which has been removed. So sometimes you may say what is the modification or the alteration that is done in the Viva, they may ask you. So the initial 5 things that were included were bilirubin, albumin, prothrombin, ascites, and nutrition were there. And nutrition was removed and encephalopathy added. So that was the modification done by this to this CPT scoring. And this is the grading that you give. And if you have these points, what is the survival rate and risk involved has to be mentioned. That also is part of the answer. And once the survey is done, then just a casual mention about MELD scoring and its importance in selecting the patient for this thing. I have just included these slides just for the Viva part of it. It is not required to write these things in your theory answers. But in obstructive jaundice, you have this Dixon-Friedman risk factors. Serum bilirubin more than 11, malignant obstruction, hematocrit less than 30, renal failure, cholangitis, hypoalbuminemia. If at least 3 of the above are present, mortality is supposed to be 60%. If none of them are present, then the mortality is only 5%. So here, just like the CPT scoring, 1, 2, 3, 4, 5, and 6 points are there. In CPT, you have only 5 points. Here, you have to take into consideration 6 points, out of which bilirubin is common both for CPT and for Dixon-Friedman. Other things are slightly albumin is also there, but hypoalbuminemia is the condition. There is no grading of albumin. So here this is in a patient with jaundice when they come for surgery. Sometimes you get a patient with jaundice coming for a gallbladder surgery or a CBD stone exploration and removal. So you may get a D3 jaundice patient. There this Friedman risk factors will be very useful, and that can be included in your theory answer also. And serum sodium concentration is an important prognostic factor in patients with cirrhosis. So if they have hyponatremia, then or hypernatremia, you may have problem. Additional serum has been added into the NALD scoring system for those waiting for liver transplantation. Now, what are the high risk for surgery? With the type of surgery, it is emergency carries more risk than elective. Intra-abdominal carries more risk than extra-abdominal. Upper abdomen carries more risk than intra-abdomen, lower abdomen. And non-laparoscopic carries more risk for laparoscopic. And emergency surgery, CT surgery is more riskier than elective. And hepatic resection with the MELD score of more than 8 or CPS score of 6 is, and previous surgery where a repetition is done is also risky thing. So these are the risk factors based on the type of surgery. Similarly, patient characteristics based on the scoring system as well as the other parameters, you have the risk involved is also more. Then contraindications for elective surgery in patients with liver disease if they have active viral hepatitis or alcoholic hepatitis or fulminant hepatic failure, severe chronic hepatitis, and this CPT scoring of C with cirrhosis, coagulopathy, hypoxemia in normal conditions, cardiomyopathy or heart failure, patients with established hepatorenal syndrome. All these things are contraindications for surgery.
Bleeding
And how to
tendencies.
optimize the patient for before surgery, you have to drain if the ascites is too large and restricting the diaphragmatic movement and causing basal attesis. Hydrothorax also should be treated. Encephalopathy should be corrected as much as possible. Anemia should be corrected. And coagulopathy should be corrected before surgery. Electrolyte imbalance also should be corrected. Nutrition, of course, we won't have time to correct it, but to be addressed and try to establish if there is a requirement for parenteral nutrition. And alcohol abstinence, at least for 6 months for elective surgery, is very important. Anti-endotoxin measures to reduce renal dysfunction and coexisting illness like COPD, hypertension, diabetes should also be optimized. Now, anesthetic consideration, system-wise, you can, instead of narrating all the pathologies, I thought you will be able to easily correlate with the anesthetic consideration system-wise. So the ascites fluid should be drained as said earlier, and the colloid replacement can be simultaneously given to reduce the intravascular volume. And coexisting COPD should be optimized. And if there is hydrothorax, you have to remove that, which we all saw. Avoid too much of PEEP intraoperatively. This is a very important thing because it will decrease the hepatic blood flow, especially the hepatic arterial buffer response will be affected. Avoid nitrous oxide in patients with portopulmonary hypertension, as well as with comorbidity as COPD. Avoid hypoxia at any cost or hypocarbia. Too much of washout of carbon dioxide also to be avoided. And the response to one lung ventilation is poor in patients with portopulmonary hypertension. So any thoracic surgery requiring OLT should be avoided. Elective post-op ventilation may be ideal for major surgeries lasting more than 3 hours or 4 hours. Extubation should be done with the patient fully awake, and hepatopulmonary syndrome and hepatic hydrothorax is indicated for lung ventilation. And anesthetic consideration for cardiovascular system, pain in light plane of anesthesia causes decrease in hepatic blood flow. So adequate depth should be maintained. hypotensive effect of volume depletion is exacerbated. So our aim is to maintain and preserve the hepatic blood flow at all the time so that we don't precipitate an acute liver failure because of the surgical and anesthetic stress. That is the main aim. And reduction in blood flow from splanchnic as well as skeletal muscle should be avoided. Blunted vascular response to exogenous vasopressors may be there in liver failure patients. So they may not respond to your vasopressors as a normal patient. And the volume expansion has to be done very judiciously. You can overhydrate or you can dehydrate them. So as you rightly said, we have to maintain goal-directed fluid therapy will be the best way to maintain normal volume. And anesthetic consideration with regard to cardiovascular system continuing, PCWP and CEP guided flow management, low threshold for starting vasopressors, low threshold for volume overload, propranolol to be used for prophylaxis and mask the signs of hemorrhage. Diuretics should be used with caution, and cirrhosis cardiomyopathy may be present as an indicator, which is a contraindication for, it is indication for liver transplantation at the earliest. And with regard to renal function, urea falsely low due to decrease in hepatic production. So, patient may be actually having a renal impairment, but urea will not be raised like in a normal patient because the urea production takes place mainly in the liver. Bilirubin lowers the measured serum creatinine. Underestimates again, that is will be a false answer. And renal function assessed by iothalidomide or EDTA clearance rather than depending upon the urea clearance. Avoid aggressive diuretic therapy, which may precipitate hepatic encephalopathy or hepatorenal syndrome. And the absence of response to spironolactone, that is, these potassium sparing diuretics are given at the dose of 400 milligram per day. Furosemide 160 milligram indicates ascites becoming refractory. So this is mainly given as a treatment to reduce ascites pharmacologically. But if it is not responding, it means patient may need only drainage and not pharmacological therapy. And titrate evening before surgery and start IV fluids while fasting also so that they don't become dehydrated. 1 to 2 ml per kg per hour to maintain urine output of at least 1 ml per kg to prevent hepatorenal syndrome. Avoid morning dose of diuretics if the patient is already on diuretics. And intake output chart and in the post-op period is very important. And CEP guided fluid management, avoid hypotension in the perioperative phase, maintain BP, urine output at least 1 ml to achieve both throughout the operative phase. If not, you can use mannitol or furosemide infusion. Avoid NSAIDs and aminoglycoside group of drugs. Cirrhotic also have a risk of acute tubular necrosis in the postoperative period. And HR also is orthotic liver transplant, not one lung RTC. So it's an indication for liver transplantation. Now, anesthetic considerations in the presence of gastroesophageal varices, blood loss may be very high. They will be on propranolol. Airway should be protected. Crystalloid and colloid resuscitation can be done. And vasopressin may be the drug of choice. It's somatostatin or octreosteroid. Now, anesthetic consideration regarding ascites. The ascites increases the risk of aspiration by increasing the intra-abdominal pressure. Along with GET motility is also affected, and they may have GERD also because of hiatus hernia. And PICD can be prevented by concurrent administration of salt-poor albumin and other colloids. Ascites is said to be refractory, and if there is no response to the maximum dose of furosemide and spironolactone, which should be considered. It is something like a dialysis for the kidney, which is thought of a very important intervention for liver failure patients. And tense and refractory ascites should be drained adequately before the surgery. And post-operatively, wound dehiscence may be very common. So abdominal wall herniations are common. Atelectasis in the lung is very common. And 1 liter of ascitic fluid is equal to 50 ml of 25% albumin. It is 1 liter. It roughly contains 10 grams of protein. So this question may be asked. And albumin should be ideally used in case of LVP, more than 5 liters per day, and half of the albumin during procedure and other 6 hours later. And the hematology, avoid drugs precipitating bleeding like NSAIDs or warfarin. And liver biopsy can be safely performed only if the platelet count is more than 50,000, not less than that. Avoid intramuscular injections to prevent any hematoma at the injection site. Hematocrit should be maintained around 30%. Anemia should be corrected preoperatively with blood transfusion or a packed cell transfusion. Thrombocytopenia in hypersplenism as a rule is mild, and severe thrombocytopenic ischemia indicates the development of disseminated intravascular coagulation. And platelet count should be checked, and all coagulation parameters should be checked. As we said, with nowadays we have the thromboelastography, which is a very useful bedside testing for coagulation assessment. So we can use that. And adequate blood and blood components should be arranged before surgery. And we can have an invasive blood pressure monitoring in cases, major cases which may last for a longer duration with a lot of fluid shift. Blood loss should be closely monitored and should be corrected. FFP should be given when crystalloid, colloid, and packed cells are given to replace blood loss. And so 1 unit of FFP equal to 1 liter of packed cells is equal to 250 ml of crystalloid. This is the equation that we can use. And hypothermia should be avoided. And blood should be minimized, loss should be minimized, especially if there is prostate or other ortho surgeries. You can use tranexamic acid. Correct prevent factors that increase bleeding, intraoperative factors like dilution, hypothermia, thromboelastography assessment, as I said earlier. Universal precaution: if the patient has an active hepatitis, all the team members should have followed universal precautions. Even with 0.04 ml of blood is enough to infect the anesthesiologist. So we should be very, very careful in avoiding any stick injuries to the medical personnel as well as the paramedical people. And regional anesthesia not contraindicated if the coagulation parameters are normal. Now, what are all the criteria for giving a neuraxial block? Platelet count more than 1 lakh is safe, 70,000 to 100,000 safe, but within this, if the coagulation is normal, coagulation screening is within normal level, less than 70,000 is considered unsafe. Prothrombin time, INR should be more than 1.5. If it is more than 1.5, it's unsafe. And similarly, APTT more than 40 seconds is also considered unsafe. Coming to neuraxial, epidural is preferable to spinal because of the lesser sudden hypotension. LA dose should also be titrated because liver has to ultimately metabolize the local LA agents, and toxicity can be precipitated. Hypotension is more likely than with the higher doses. Strict aseptic precaution because they can catch infection easily. Epidural use for postoperative analgesia decreases the use of other opioid drugs which are mainly eliminated by the liver, and also prevents the pulmonary complications. And specific conditions like obstructive jaundice, you have to think about coagulopathy, endotoxemia, hemodynamic instability, renal failure, altered drug handling due to cholestasis, impaired wound healing, and so measures to be taken, especially for renal failure, by giving preoperative mannitol infusion, which can to some extent help in that. Ascites treatment, specifically salt restriction, fluid restriction, spironolactone, furosemide, and albumin replacement. And similarly, coagulopathy treatment, vitamin K, FFP, platelet transfusion, cryoprecipitate, and desmopressin. And hepatic encephalopathy management, care of airway, hemodynamic, acid-base phases, identify and correct precipitating causes, restriction of protein intake, avoid narcotics and sedative, reduction of blood ammonia by lactulose and bromacin. And what are the goals? The goals to maintain adequate blood flow, oxygen content in the blood to the liver. So demand relationship is maintained. High inspired oxygen to prevent hypoxemia, maintenance of adequate cardiac output, avoid hepatotoxic drugs, avoidance of relative overdose of anesthetics, normocarbia, normothermia, adequate hematocrit, adequate volume, maintain urine output, coagulation parameters, glucose, calcium, and electrolyte. Intraoperative monitoring, regular pulse oximetry, NIBP, electrocardiography, and invasive monitoring is required, PTCO2 and temperature. Muscle relaxants, of course, pancuronium and all these things are nowadays not available, but atracurium and cisatracurium are the safest, and succinylcholine action will be prolonged. Opioids, these are all the restrictions that we have to do. Remifentanil can be used because it is mostly stabilized by esterases, and this drug being available now in the market, you can use them safely. Now, halothane, this slide is included mainly from Viva point of view. So, halothane associated hepatitis can be two types. Either it is immune mediated or direct effect. Direct effect is due to reduction in the hepatic blood flow, and immune mediated because of the trifluoro antibodies to this particular compound. Mild self, the type 1 or direct effect is mainly self-limiting, whereas the second one, immune mediated, will be more resulting in massive hepatic necrosis. And the effect of anesthesia on the diseased liver, hypercarbia will cause sympathetic stimulation, pancreatic vasodilation, and thereby decrease portal blood flow. And PCO2 should be maintained between 35 to 40. Neither hypercarbia nor hypocarbia should be caused. Biochemical and hematological monitoring, we have to do the hematocrit, serum electrolyte, blood glucose, ABG, and coagulation parameters. Post-operative period, monitor signs for liver decompensation, including worsening jaundice and encephalopathy. Bilirubin, prothrombin time to be measured. Renal function, because even in the post-operative period, you can get hepatorenal syndrome and renal shutdown. And they can frequently go for hypoglycemia. So serum glucose is very, very important, as hypoglycemia is often an important complication. And patients with CPT B grade who undergone should be shifted to ICU and may to be ventilated post-operatively. Fluid and electrolyte acid-based coagulation defect may be taken care of. Sedation and pain medication should be used very cautiously. Chest X-ray should be immediately taken to see the lung fields and check central as well as pulmonary catheter position if you are using a central line, and monitor the patient for features of hepatic decompensation. Okay. So these are all the things that I thought of should be. In this approach, you can avoid unnecessarily writing about the individual pathology of each and every system. Instead of that, you can combine both the implications of the pathology that is happening in the various system and its relevance to anesthesia in a single approach, so that you can save time and complete your answer in the examination. Okay.
Yes, sir. Sir, can I add 2 points, sir?
Please, ma, go ahead.
Repeated exposure, halogen, as you said, one is immediate due to hypoxia, and second thing is repeated exposure can increase a particular enzyme called glucuronide S transferase, which is a very rare enzyme. And second, safest inhalation agent is xenon in hepatic diseases.
Yeah. But is it available?
It's not available, but it's for the sake of academic.
But
So
of
I
all
still remember
the
the
agents
mnemonics
that are
you taught us when we were students. You taught us the 6H: hypoxia, avoid hypoxia, hypercarbia, hypoglycemia, hyponatremia, hypokalemia, and hypothermia. I still remember the mnemonics, sir.
yes.
6H.
But also this of all the agents, inhalation agents that are available, isoflurane is considered even for liver
Isoflurane is
transplantation
maintains a
because
liver
it preserves
architecture.
the
It's the
HAB.
safest.
Hepatic arterial buffer response is well preserved
And
by
that is the safest
isoflurane
now.
compared to other agents. That is
Yes,
the
sir. Yes, sir. Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, madam. Thank you, Dr. Sir.
Kamachi,
Sir.
we will have that congenital